This talk was originally supposed to be given by Dr. Ken Ott, one of the neurosurgeons I worked with for the past 30 years, and he fell ill. A couple of days before the meeting, actually, he sent an email that he could not be here. So I kind of scrounged up the slides from my talk, and Tim Solberg gave me some of his slides, and also Vinay Gandhi. So it's a conglomeration of many of our talks. I think it came out all right. So the three most common benign intracranial tumors that we treat are meningioma, vestibular schwannoma, and pituitary adenoma. If you look at this collection of books, Harvey Cushing actually wrote the monographs on these three lesions going back to 1910 and 1920. Ken Ott, actually the neurosurgeon that I've been working with, has been practicing for the past 38 years, and in his judgment, the most significant neurosurgical advance during his career of close to 4 decades is the stereotactic radiosurgery. I think Ken has done about probably close to 3,000 stereotactic radiosurgeries using both gamma knife and LINAC. I'm going to move on to meningiomas. When somebody is diagnosed with a benign meningioma, often one can observe, especially if it's an incidental finding without any symptoms, elderly patients and a calcified meningioma, which portrays actually better prognosis. Surgery is often done when there is symptoms from this particular meningioma and also large tumors that are not quite amenable for stereotactic radiosurgery or SBRT or SRT. Typically with surgery for meningiomas with gross total resection, we have a local control of about close to 80 to 90% at 15 years, and that is essentially almost a curative treatment. For subtotal resection, the local controls are actually relatively poor in the 10 to 30% range at 15 years, and often we end up adding post-operative radiation therapy, either planned depending upon the location of the lesion in the brain, or sometimes actually once you follow them for 3, 4, 5, 6 years, and if there is any growth in the lesion, then you go and actually add radiation therapy at that time. Typically, radiation therapy is used for inoperable lesions that are actually deep, difficult to access by surgery, progressive or symptomatic lesions, subtotal resection in the areas where there is a recurrent risk that could potentially cause problems, and obviously one would use radiation therapy for the recurrent tumors. Also, you can do stereotactic radiotherapy for the lesions that are too big to be treated with stereotactic radiosurgery, and once again, one can do conventional radiation therapy also. I have listed about 4 different papers that are published in the literature that looked at the stereotactic radiotherapy compared to the conventional radiation therapy that actually show that the 5-year progression-free survival is pretty good in the 90 to 100% range, with a relatively small risk of late complications in the 3 to 5% range.